The worst.
All right, well, welcome everybody. We'll go ahead and get started. So we've got a lot to get through here and hopefully can get through all of it. Excited to see everybody. And hopefully this will be one of many of these types of presentations. So today we're going to focus on COPD, and we're going to look at a lot of different aspects of COPD. We're going to walk through a case study from the beginning to end of care and talk about things along the way. We'll talk about anatomy, some of the pathophysiology, symptoms, physical examination. We'll get into treatment, how to manage these patients in general, manage symptoms and manage caregivers. And along the way, we'll talk about how the different roles that we play with palliative care and hospice and all the team members factor into this. So a lot to cover. On some of these in the past, we've made it interactive, and I've
Dr. Hughes, it's Sarah. We don't hear you anymore.
Sorry, I think I got muted there.
Okay.
All right. So I may ask some questions, but if you have a question, either just unmute yourself and jump in and ask, or you can do the group chat too, and I'll try to keep an eye on that if I can. All right. So this follows along with the CAPC case presentation on COPD, and then I'll be switching back and forth from that to some of my other slides, so bear with me a little bit here. So we're going to start by learning just a little bit about our patient, Javier.
My name is Javier. I was diagnosed with something called COPD about 15 years ago when I retired as fire chief from the Miami-Dade Fire Department. I was having a hard time on the job and getting more tired, but I assumed it was just because I was getting older. Then, when I retired, my wife, Selena, noticed I was still tired a lot of the time and that I was having trouble breathing. And I was always strong as an ox and only got checked out at my yearly physical at the fire station. I finally saw a doctor after I retired because my wife made me go. The doctor told me I needed to quit smoking, which I did. It was the hardest thing I've ever done. I've been taking different medications and using my inhaler for years, and I've had to go to the hospital many times, including twice when they put me on a breathing machine. To top it all off, I have had bad pain in my hip from all the medications, so I barely leave the house. My breathing has been even worse than usual lately, but I don't ever want to go back on that machine.
All right, so there is Javier, our gentleman to start with here. To start just a little bit of the demographics of COPD, how many people in the United States are currently diagnosed with COPD? I'll go ahead and give you the answer on this one, but it's 15 million people. So currently 15 million people who are living and dealing with COPD here in the United States. And that's where we come in. So how can we help patients and caregivers like Javier and his wife Selena manage COPD? Because as we know from taking care of those types of patients, COPD can be frightening, it can be painful, and it's costly as well, which we'll get into. And integration of core palliative care practices and hospice practices can help reduce the burden of COPD. And so we can play a big part in helping these patients to live well. So COPD by the numbers. We know that COPD is progressive and it's fatal. COPD is the third leading cause of death still in the United States. So it's way up there. And it's preventable. Really 80% of COPD deaths are caused by smoking. So a major problem. It's chronic. Most patients, once they're diagnosed with COPD, live on average 14 to 18 years from diagnosis. So it's not an acute condition. Patients are living a long time with COPD and can be helped at a lot of points along the way. So disease treatments can slow progression. So that's one key takeaway about COPD. We don't have any cure. So once the damage is done to the lungs, there isn't much you can do to reverse that very much, but the treatments that we have can slow progression. Smoking cessation does decrease mortality at all ages, so we'll talk about it a few times during this, but it's always good to encourage patients to quit smoking no matter what stage of disease that they're in. People with COPD utilize hospital a lot, so about 715,000 hospitalizations and 2 million emergency department visits each year for COPD patients, and a whopping $50 billion in annual healthcare costs for COPD patients. So as we said, it's preventable, it can be treatable, and it's chronic, and it's characterized by persistent airflow limitation, and it's a chronic inflammatory response to irritants. And so we'll go through that a little bit further here, but it's progressively disabling and ultimately fatal, as we know by taking care of these patients too. What are some of the symptoms? So we'll go over those in detail, but we know dyspnea, shortness of breath, which is defined by a sensation of shortness of breath or difficult, uncomfortable breathing. Dyspnea on exertion may occur as during normal exercise, but it can be also indicative of a disease when it occurs at a level where patients are not able to do activities that they used to be able to do. Chronic cough is often seen, and chronic sputum production. Spirometry is required to make the diagnosis of COPD. We'll talk about that in a little bit too. So a little bit of pathophysiology review. COPD is caused by chronic inflammation that's initiated by noxious particles. So most of the time that's cigarette smoking, but other chemicals can do that, environmental exposures, secondhand smoke. And from there, over time, with that chronic inflammation, you get airway obstruction, collapse of those airways, spasm of those airways, a lot of mucus, swelling, and then ultimately air trapping and hyperinflation of the airways. So let's switch over and review a little anatomy here so nobody get too scared. We've got our little gentleman here, and he's got the trachea, which of course is the large airway that takes air from the nose and the mouth down into the lungs, and then that branches into the right and left bronchus, which then further branches into the bronchial tubes, and those get smaller and smaller until eventually you end up with the Acinar unit, which are the alveoli. So those alveoli are the tiny little sacs that the lung has tons and tons of, and those alveoli are what are responsible for transmission and transportation of oxygen and carbon dioxide. So you take a big breath in, that oxygen goes all the way down into those alveoli, and then you've got your vasculature around those alveoli. So your pulmonary arteries, the red ones, they take oxygen through the tissue of the alveoli, and they carry that oxygen out into the blood, into the other tissues in the body, to where your body uses that oxygen, and then it sends the oxygen poor blood and carbon dioxide rich blood back through the pulmonary veins, back into the alveoli with it, and you breathe out that carbon dioxide. So basic physiology with a lot of complicated parts. So the types of emphysema as they relate to that anatomy, it's type of COPD, emphysema is the most common one. So a lot of times you hear those terms interchangeably, emphysema and COPD. So emphysema definitely is a type of COPD, but there are others as well. Chronic bronchitis is another type of COPD, and then actually asthma is a type of COPD. We don't always associate that as COPD, but technically it is an obstructive process. So when you look at the types and what's actually happening in the lungs, so on the left side of the picture, which is the right lung, you have the picture of chronic bronchitis. So we talked about the bronchus narrows down into the bronchial tubes, and with the little picture on the left bottom there, you see in chronic bronchitis, you get inflammation with a lot of mucus production, and that plugs those airways up to where the air doesn't get through as well, not efficiently, so you get the symptoms of COPD. On the right side of the picture, which is the left lung, those are the alveoli. So you see with emphysema, that alveoli has been damaged. It's just been chronically inflamed to where it destroys those tiny sensitive tissues. Air goes in, but it doesn't go out as well. You get air trapping and you get poor oxygen perfusion then into the pulmonary vasculature, and that's ultimately what causes problems with the COPD. So in review with all that, you've got chronic inflammation, increases your number of goblet cells, increases mucus gland and mucus production. Those glands get larger. And then over time, you get fibrosis. So you get scar tissue essentially along those structures that further causes problems with the way the lungs work and the way the alveoli work. You get narrowing, reduction, and destruction of those airways, collapse of the airways. And then over time, you get changes in that pulmonary vasculature, and those pressure changes are what can also cause then cardiac problems along the way. So if you didn't have all that memorized already, I can send these slides out later if you're interested. Just let me know, and you'll have a nice review at your fingertips here. So with symptoms then, when you put all that together, it's logical that at first, as you're having some of that tissue damage and that tissue inflammation, you may not have any symptoms, or the symptoms may be very mild. So there are a lot of people out there with COPD that has just not got to the point where they're having any symptoms yet. But as it gets worse, then you can feel short of breath as those airways are being damaged and you're not getting air in as efficiently, especially when you're moving around. Then it can cause wheezing, which we'll listen to in a little bit. It can cause coughing and mucus production, and all of that work on the lungs can make you very tired. All right, let's check on Javier here. So some of those risk factors we talked about, certainly cigarette smoke, occupational exposure, environmental tobacco smoke, so in other words, secondhand smoke, pollution, and then you have some of the social risk factors. So socioeconomic status, being disadvantaged in that respect can correlate with higher morbidity and mortality with COPD. Advanced age makes sense that affects people with COPD at older ages more than younger ages. Hereditary, so we won't talk much about this other than here, but don't forget about alpha-1 antitrypsin, so the genetic condition that can cause COPD as well. We don't see that as often. And then infections can cause more inflammation that can cause problems with COPD. So when we look at Javier and we look at patients that we have with COPD, it affects their lives, and we know that by seeing these patients. They're not able to do things that they would like to be doing or that they need to be doing, such as these things. So this fellow here, he's not able to take out the garbage anymore or clean the house. It affects his sleeping. It affects walking his dog. All of these things that can also lead to loss of identity and can lead to depression as well. And so that's part of where we come in to help with that, to not only physically help with some of those services by what we provide, but also just help to normalize that to patients. So by telling the patients that this is part of the disease process and that they're not alone in that. Because in this case, Javier, he feels like a prisoner. He's scared. He's trapped by his own body here. He can't do things that he used to be able to do, like cut the grass, meet up with his friends, or spend time with his wife. So we'll talk a little bit about diagnosing COPD. Most of the time when we're dealing with patients on palliative care or on hospice, they've already been diagnosed, but it's good to learn a little bit about how it's diagnosed and how it's tracked over time. So how many patients are out there basically with undiagnosed COPD? So we said 15 million patients are living with COPD that they've been diagnosed, but how many don't have a diagnosis but might be having symptoms, or they're just undiagnosed yet? That's actually 12 million people. So 15 million people with a diagnosis, but another 12 million that are undiagnosed. And it's important that physicians and other providers recognize symptoms to be able to work those patients up. It's important because, as we talked about, that prognosis for COPD patients, they live 14 to 18 years after diagnosis. So the earlier that you can diagnose COPD, the more that you can do with some of those modifying treatments that we have to impact their quality of life and survival. For patients living with COPD, does disease-directed treatment improve quality of life but have no impact on survival? And that's actually false. So those treatments, they improve quality of life and they can improve survival. Like I said before, they don't cure COPD, they don't reverse a lot of the damage that's already been done, but they can prolong the decline in those patients. So early diagnosis can be important. What are some of the red flag or cardinal symptoms for COPD? So let's look at those. Shortness of breath, sure, that makes sense. Wheezing actually is not. Certainly patients with COPD can have wheezing, but that's not a cardinal symptom for COPD. Chronic cough is. You see that with emphysema, chronic bronchitis, and a lot of times with asthma. Sputum production is. And chest pain is not either. That's not to say that patients won't have chest pain, but it's just not one of the cardinal symptoms to look out for. Which are risk factors? We've already talked about some of these, certainly tobacco, exposure to irritants. Gender is not, pollution is, and then family history can be too. So that's the takeaway here, that COPD doesn't really care if you're male or female, it can affect you just the same. So spirometry. So you have symptoms, you have risk factors, and that should lead somebody to think about doing spirometry on a patient. Spirometry is required, so big stop sign. To have the diagnosis of COPD, you really need to do spirometry. Does it require a pulmonologist? Nope, sure doesn't. It's easy to do, just simple equipment that can be done in many primary care offices. Spirometry should be performed at baseline and after the administration of an adequate dose of short-acting inhaled bronchodilator, and that is true. That's how you determine whether that limitation in airflow is reversible, like it would be in asthma, versus not reversible, like it is with COPD. Spirometry should be performed immediately after the administration of an adequate dose of short-acting inhaled bronchodilator, and that's actually false. You want to wait about 15 to 20 minutes. So you perform the spirometry, have the patient blow into the machine, you give them the inhaled bronchodilator, wait about 15 to 20 minutes, and then you repeat. So you don't want to do it right away. So with that, so spirometry numbers, and we won't delve a lot into this because it gets complicated, but FEV, so the forced expiratory volume in 1 second. So basically how forceful is that breath when they blow out as hard as they can, over the vital capacity of the lung. So how much air does the lung hold? So when you take that ratio, essentially 70% can confirm the presence of that airflow limitation. So that is true. And that's the cutoff for diagnosis of COPD, that ratio of 0.7. Can you use spirometry to track exacerbations and progression of disease? Yes, and that number can be important. Symptoms and patient condition is important, but the number can be important as well. So let's look at the trajectory and prognosis, spend a little time there. So we've been diagnosed with COPD. What do we do from there? How do we talk to that patient about what they're looking at for the future? Because as we know with our programs, that's important. Patient education is critical to what we're there for. So Javier, back to him, his wife calls and she's worried about him. She says that he's been experiencing more trouble breathing. He doesn't have much energy. He's out of breath when he gets dressed in the morning. She says his mood is down and he doesn't want to leave the house any longer to visit with family. So we say, well, bring him in, let's take a look at him. So based on that report, we're concerned that his COPD may be advancing. How do we assess for that? What kind of things do we look for? And what kind of things do we evaluate? Impact on function, certainly. The things that he can no longer do that he used to, that's very important. Spirometry, we just talked about that. We can use that to track over time. So that's going to be important. Chest x-ray, not so much. So a chest x-ray can be helpful to rule out other things that might be going on, like tumor or pneumonia or fluid. But chest x-ray really is not as helpful in the diagnosis or monitoring of COPD, because I've seen certainly patients who have terrible looking chest x-rays who don't have as severe symptoms or severe spirometry. And I've seen the opposite, patients with perfectly normal looking chest x-rays who have terrible spirometry and symptoms. And then of course, frequency, severity of exacerbations, how much that's affecting them, that's very important too. So why is Javier's COPD progressing? Is it because he's got inflammation in the lungs? Is it because he's got systemic inflammation, both, or neither? And that's key here. So the answer is both. When we talk about COPD, We just talked about the pathophysiology and why the lungs are inflamed and what happens there, but it doesn't stop there. Over time, the COPD causes systemic inflammation and can lead to a lot of the other problems that we see with COPD and the comorbid conditions. Airway inflammation and obstruction goes to systemic inflammation and leads to a lot of the comorbidities that we see in patients with COPD. So as we know from our patients that we see in palliative care and hospice, you rarely see somebody who is perfectly healthy other than horrible COPD. Usually they have some of these other things, and that's because of the systemic inflammation. They've got cardiovascular disease, depression, muscle weakness or atrophy, weight loss, renal insufficiency, osteoporosis, so brittle bones because they've lost weight, and it's affected their bone metabolism, and then diabetes as well. So you often see these things run together, and that certainly leads to higher morbidity and mortality in those patients. On average, the COPD patients have 4 comorbid illnesses, and that's the reason. It's not just because they're terribly unhealthy patients. The COPD can actually lead to those other comorbid conditions. So back to Selena, she says that she's noticed that Javier seems weaker. He's losing weight. His breathing is worse. Several times a day, he's just got to stop what he's doing and catch his breath. Doesn't sound good. He's got some good days, but there are more bad days than good. He's so down. He's just not the same as he was, struggling to breathe, and she's really having a rough time. So on exam, we look at Javier. He's really having trouble just getting from the chair up to the exam table. We notice he's lost 5 pounds since his last visit 3 months ago, and his spirometry is getting worse too. So when you hear that story, what are the red flags of disease progression? And this is important because this is, especially on our palliative care teams when we're taking care of COPD patients, what kind of things should be watching for or monitoring for to tell that patients are declining, not only for ourselves to know, but also to educate patients' family on. So in this case, he's got depression. He's really down, most likely because he's not able to do the things that he wants to do. He's losing weight. So we know certainly weight loss is a significant indicator of decline, one that we really need to be aware of. And he's tired. He just doesn't have the energy to do what he wants to do. So those are all important things that tell us that Javier's not doing so well. Some of the other things that we should be looking for and educating patients on and talking to them about and guiding them on: increased exacerbations. And we'll talk about that as far as treatment in a little bit. But here, yeah, how many wives, spouses, families, caregivers do we have where the patient doesn't want to go to the hospital, don't call 911, but they want to do everything they can. The caregiver wants to do everything they can and says, we got to call 911 because it's stressful for them to see loved ones going through shortness of breath like that. He's got decreased quality of life because he's not able to go golf and do things that he wants to do. He's got higher symptom burden, can't hang out with the grandkids like he wants to, and then increased mortality. So these patients die, and that's a pretty pathetic, sad picture there, but it's reality. Patients do die with COPD. So the trajectory. So this is important because we need to know what to tell patients to expect as far as how they're doing on their course of COPD. That prognosis is influenced by a lot of things, and it's really tricky with COPD. It can be hard to predict prognosis to a really exact extent, but it's influenced by severity of the disease. So we talked about airflow obstruction, by spirometry, how many exacerbations are they having? So how many times have they needed antibiotics or steroids, or been to the hospital, been in the emergency room, been to the ER, been to the urgent care, and then what comorbid conditions do they have? Because that all affects things as well. All right, I'm gonna switch gears back and talk about some of the tables that we have. So this gets into a lot of numbers, and I can send this out to whoever because these are important, but don't get lost too much in the numbers. These scales are fairly simple, and I know anybody on our team who's been around a little while, we've talked about the Bode index. It's a fairly simple scale of 4 different things. So you see on the left, the FEV1, so we're talking about spirometry results, how far the patient can walk in 6 minutes, the MMRC dyspnea scale, which if you're not using, should be using, and then body mass index. So when you take where patients are at on all those 4 scales, you assign them a number, 0, 1, 2, 3 points for each one. And then you add all those points up, and the higher the points, the worse they're doing. So you can see at the bottom of the slide there, patients with 0 to 2 points, they're doing pretty well. The percentage correlates to the 4-year mortality rate. So if you've got 0 to 2 points on this BODE index, the chances you're going to be here still talking to us in 4 years is about 80%. So then the higher the number of points you have, the lower the chances are that you're still going to be here in 4 years. Once you get up to 7 to 10 points, there's only an 18% chance that you're still going to be around in 4 years. So 4 years is still a relatively long time when we're talking about hospice patients and some of our palliative care patients too. When you get to trying to predict prognosis less than that, it can be more difficult, which we'll see here in a second. If we're not familiar with the MMRC dyspnea scale, and this is a palliative core measure that we really should be monitoring on our patients, it's from 0 to 4. 0 is the best, so they're really, somebody's not bothered too much with shortness of breath unless they're really hoofing it with exercise. Up to grade 4, that means they really aren't able to do much at all. They can't leave the house or do simple activities of daily living without shortness of breath. Another scale that's important to know, and this is a busy slide, I know, but if you look on the left is the GOLD stage. So the GOLD stage for COPD, really, I think, from what I could see, is the more accepted scale for defining severity of COPD right now, and it's simple. There are 4 stages, and so there's GOLD 1, 2, 3, and 4, and then it corresponds to severity. So it's really easy to remember: mild, moderate, severe, and then very severe. And those correlate to what their FEV1 actually is. So patients with mild disease are over 80, and then patients with very severe stage 4 disease, less than 30. So typically we're talking about hospice at that stage with our stage 4 patients who are less than 30. Most of those patients are going to be appropriate for hospice. When we look at other prognostic indicators, we've talked about airway responsiveness, how well they're responding to their medications anymore, whether or not they're continuing to smoke cigarettes. Patients' low body mass index means their muscles are wasting and they don't do as well. Certainly HIV infection would increase their morbidity, increased bacterial load in the airway, elevated CRP, males, and CT presence of that. So just some other things that, if you do have that information, can help look at prognosis. There's another slide with survival rates, which I can send out if anybody wants. But this is a picture that really you can outline for almost every significant disease state that we take care of, and it's the disease trajectory. So when you look at this over on the top left, that would correspond to when patients are first starting to have symptoms or impaired function from COPD. They're generally doing pretty well, and then they start to decline. So all those things that we talked about with airway inflammation and airway collapse and mucus and cough and wheezing and all those things that are going on, the patient's declining, and then they may hit an exacerbation. So all of those downward peaks are COPD exacerbations. And you notice, and we know this from clinical experience, when you treat a patient for COPD exacerbation, they rarely come back up to 100%. They usually aren't back to where they started from. They usually come back at a lower percentage. Over time, then with more exacerbations, they fall further down that curve, eventually to the point of death. What's hard about COPD to predict exactly is that we know that at any one of those sharp declines with an exacerbation, the patient could die at that point. So while this curve represents some patients with COPD, we know others don't even make it that far, and they may not make it through any one of those exacerbations. So it does make it difficult past being able to predict survival to 2 to 4 years and past, once you get to severe COPD, it's not as specific as it is like with some of the cancer diagnoses that we have, where we can predict survival to, a month to 4 months to 6 months to a year, but it's harder with COPD. But the important thing is that we can recognize those decline indicators to just be able to have those discussions with patients and actually draw this out. I think it's good to have this picture or draw something like this out to show that patients don't always come back to their baseline, and then that's fairly normal in the course of COPD when that does happen. This is a busy slide too, but basically we're just talking about when to start discussing palliative care with these patients and how to do that. And we've had some other discussions on how to bring those up. But bottom line is just using some of those indicators of decline that we've talked about, and using some of those symptoms, using things like hospitalizations or emergency department visits, using that curve, focusing on symptoms, focusing on test results. So if they've got spirometry that's declining, if they've been going to a pulmonologist or a primary care that's doing spirometry, changes in oxygen requirement, as we're starting to see those decline, those are things you can bring up to have those discussions about what the patient's goals are, because you know that the patient's not doing as well. And then speaking of palliative care indicators, just a review of our hospice criteria for pulmonary disease. So it's straight from the LCD guidelines. So patients at 6 months or less, which again, it's hard to specifically predict that, but in order to qualify and be eligible for hospice, they have to have severe lung disease, and number 1, with dyspnea at rest that's poorly responsive to bronchodilators, and typically that's the FEV1 of less than 30%. So that's that stage 4 gold, very severe stage COPD. Usually they've got other progression signs. So they've been to the emergency department, they've had hospitalizations, exacerbations, and those things too. And then they also have to be hypoxemic, either a PO2 done by blood gas of less than 55, or regular pulse ox of less than or equal to 88% on room air, or they can also have high PCO2 greater than or equal to 50. And then the other things that we want to look for, because they're supportive criteria but not required to be eligible for hospice, are right heart failure, which is cor pulmonale, progressive weight loss over 10%, and resting tachycardia. All right, I'm going to switch this over so we can listen to some exam findings, because I think those are important as well. All right, so the first one we'll listen to is just wheezing. Pull it up on YouTube and it'll probably give me an ad.
Airborne immune support for the whole family with more than just vitamin C.
All right, so wheezing, most of this caused by narrowing. It can be higher or lower pitched, kind of like a whistle. In COPD, usually it's going to be more on the expiratory phase, and so it's often going to prolong. Since those patients are trapping air, they have that prolonged expiratory phase. Not always in a particular spot, but it may be. In this case, first you can hear it throughout the chest wall, but it may be too. All right, then moving on to rhonchi. So rhonchi are lower pitched. So these are sounds that are made by the bigger airways from turbulent flow, usually from mucus production. Almost the gurgling or bubbling sound, and that's from mucus in the larger airways. So you can see that in COPD, bronchitis, from pneumonia.
Next, we've got crackles, which is sometimes called rails, but I don't like to call it rails because I don't know what a rail is, but I know what a crackle is, and it sounds like a crackle. So these are high-pitched crackles. So these are from the smaller airways and even the terminal parts of their units as they're popping open. So they're not as flexible. They might have some mucus in there. And it sounds like wood crackling or Velcro is what it sounds like to me. You might hear it on inspiration or expiration. So in this case, these are fine crackles from a patient with heart failure. So you can hear it with heart failure, pneumonia, pulmonary fibrosis, you'll hear it with. And then atelectasis too. So if a patient's been not taking deep breaths, or if they've been bedbound, sometimes they can just have atelectasis, which will cause that. And these are lower pitched crackles. It's a little bit longer in duration, lower pitched, really more coarse. So these are the bigger airways that are popping open. And then the last one doesn't really have any specificity to COPD, but since we're talking about lung exam, I just thought this was interesting, and that's stridor. So stridor is upper airway obstruction. And so you might hear this with epiglottitis in children, or sometimes babies, just they've got that softer airway tissue and they might have a little bit of stridor. But usually when you hear this, you think that there's something obstructing the upper airway. In our patients, typically you'd hear this in a patient with an upper airway tumor. So if they've got a malignancy in the larynx, or sometimes even in the esophagus, they might have a stridor sound that indicates that. So those are good things to listen for. And I think it's important to recognize those sounds because it can tell you more about what's going on if you're evaluating a patient with dyspnea. So moving on a little bit to the treatment of COPD. 4 main types of treatment. Actually, I'm going to switch audio here.
All right. So 4 main types of treatment. We're going to focus on medications because I think those are the things we see and get confused by a lot. We'll go through those. Oxygen, it's pretty self-explanatory. If patients are having trouble with their oxygenation, adding oxygen can help in several different forms. Pulmonary rehab, which is basically just exercise therapy to help with the lung and to help with oxygen needs. And then we won't talk about it, but surgery. So these are talking about some of the newer endobronchial procedures they're doing, lung resections of the bad parts of the lungs, and then even lung transplant can be done in these patients. So with medications, we're going to focus on 2 main classes. So even though there's a ton of different inhalers and different medications, most of them can be broken down into simple classes. So we have the bronchodilators. And of those, on the left, you've got beta agonists, both short and long acting. On the right side, we've got our muscarinic antagonists, short and long acting. And then we have our glucocorticoids or steroids. So we've got inhaled and oral forms there. So beta agonists, just to review there. So those medications work by relaxing the smooth muscle in the bronchioles. by activating the beta-2 receptors. They can come in a nebulized form or in the MDI, metered-dosed inhaler. Really, the only short-acting beta agonists are still albuterol, which you'll see branded as ProAir, Ventolin, or Proventil, and then levoalbuterol, so just an isomer of albuterol that doesn't cause as much side effect as albuterol. So those are short-acting and really just for as-needed basis. So typically mild disease, either COPD, emphysema, or asthma. Side effects of those: throat irritation just from the medication, cough due to the throat irritation. And then, so if you think about it, our cardiac medications, our beta blockers, those inhibit cardiac activity. So you see low heart rate, low blood pressure. So if we're agonizing or turning on those beta switches, we can get some of the side effects that we see with albuterol: nervousness, tremor, heart palpitations, elevated heart rate. Then there are long-acting beta agonists. So these are more of a controller medications, and there's quite a few of those, more and more coming to the market, and they've got funny names. But if you look, all those end in ROL. So if you see an inhaler and it ends in ROL, you can guess it's a beta agonist. So if it's not albuterol and if it's not levoalbuterol, then it's one of the long-acting. So several there, and again, I can send these out so you've got that for reference, because seeing patients with all these, I think it just depends on which drug reps been by that day to peddle their samples, because there's just more and more that pop up all the time. And then we've got our muscarinic antagonists. So those block the action of the acetylcholine neurotransmitter at the parasympathetic sites, still in the smooth muscles, and then it causes those muscles to relax so the air can get through better. Again, you can have these in nebulizer or meter dose inhaler. Short acting is really just ipratropium. So our Atrovent, Combivent, or if it's in combination with albuterol, that's our Duoneb treatments. So our short acting, just ipratropium. Long acting, lots of these are coming to the market too and have fancy names and fancy inhalers. And you can kind of tell the first three, which are the common ones, and those end in IUM. So if you see an inhaler that ends in IUM, you know it's in that same family as ipratropium. It's a muscarinic antagonist. And then Revifenacin, I think I'm saying that right. I haven't seen that one used much, but that's a newer muscarinic antagonist. And then interestingly enough, too, glycopyrrolate is a muscarinic antagonist. And so you'll see that in some inhalers, but then of course we also use that in patients for secretion management, because it can have a drying effect. So it can actually help as a bronchodilator, but also to dry up secretions. So that might be something to think about in a COPD patient who has those issues. Side effects, so dry mouth, hence the drying of secretions, headache, constipation, urinary issues, UTI, back pain, those things you might watch for if you're using a muscarinic antagonist. Then our steroids, so the inhaled steroids. We talked about how COPD has a lot of inflammation associated with it, and so steroids are anti-inflammatories. So when they use the inhaled steroids, it acts directly on the tissue. Patients sometimes, if they've had problems with oral steroids before, they might get scared about inhaled steroids, but there's minimal systemic absorption with inhaled steroids, so you can reassure them that they're not going to get the side effects that they did if they took prednisone and had a bad reaction. So you can see a few of the different inhaled steroids that are out there. Typically, those are long acting, since steroids do have a longer half-life. Side effects of steroids: fatigue, headache, thrush. So you want to make sure you tell them to rinse their mouth out. And then sinus infections can happen too for the same reason. And then oral steroids. So with severe COPD, patients who are no longer able to use those inhalers effectively, or for exacerbation, sometimes patients need oral steroids. So these taken systemically then do help reduce inflammation and help with the exacerbations. The most common ones you'll see used are still prednisone and dexamethasone, very effective. And side effects that we've seen patients complain about with thrush, insomnia, anxiety, I say those are the typical ones. Some patients feel great, they get a little rush of energy and they feel great on steroids, and others get so anxious and nervous that or have trouble sleeping, that you have to reduce the dose a little bit. This is just more for reference because there are a lot of different combination inhalers that are coming out, and they have goofy names, but really they're just, if you break down the medications in them, they're all just different combinations of either beta agonist with muscarinic antagonist or steroid with a beta agonist. So they're just combinations of those medications. So it may be useful to just at least be familiar with those. So if you're seeing patients for an assessment or seeing patients on palliative care and they're on a goofy named inhaler, chances are it's not a fancy drug. It's just one of these packaged combination inhalers. There's one triple combination inhaler down at the bottom called Trelegy, and it's an inhaled steroid, muscarinic antagonist, and beta agonist. So I've seen a few patients on that coming through so far. It's fairly new. One thing just to mention, because you might see patients on Daliresp, which is roflumilast, and it's got anti-inflammatory properties, but it's a phosphodiesterase 4 inhibitor, and it's used in patients with moderate to severe COPD to help prevent exacerbation. So you might see patients on that, and that's an oral medication. It's just a daily pill. When we're taking care of patients, so our goals are, like this says here, minimize symptoms, diminish perception of symptoms, because those can be anxiety producing. And so the more you can educate patients and help do non-medication therapy, the better. And we'll talk about those a little bit. Reduce the symptom impact, and then modify the experience of the symptoms as well. When we're talking about treatment of COPD, it's important too, as we're educating patients, to think about nutrition with COPD. As we know, COPD patients tend to lose weight. Breathing and all that inflammation use up a lot of calories, and so most patients aren't able to eat enough because of that, and they lose weight. Some of that's normal, so you can normalize that to patients or family members who are really worried that patients are losing weight, and let them know that that's part of the disease process. But some of the things you can give them for tips are to eat small, frequent meals that are nutrient dense. Part of the reason for the small meals is because if as we know, if a patient has a big meal and they've got COPD and they've got a big full belly, it pushes on their diaphragm, and they a lot of times get short of breath. So you'll hear a lot of times patients with COPD aren't able to eat large amounts. Rest before meals, have them take nutritional supplements, or in some cases they might need prescription medications to help stimulate their appetite. We'll go through this fast, but just talk about COPD exacerbations, because we take care of patients who do have exacerbations. And with treatment of that, it's things that we've already talked about. They might need increased frequency or use of their beta agonists, so they may need albuterol more frequently. And those really are the mainstay of treatment for an acute exacerbation, at least to start with. And for patients who are managed at home, they may be able to use an MDI, but they may also need a nebulizer. If they're in a severe exacerbation, they may not be able to use the inhaler as well and might need nebulizer. Patients a lot of times think that nebulizers are helpful. There's not a lot of evidence that nebulizers are more effective, at least for patients that still can use an inhaler, but a lot of patients feel like the nebulizer helps them more, and that's okay. It's the same medication. The anticholinergics, so those antimuscarinic medications, are good too. So ipratropium, so we use Duoneb a lot, the combination albuterol ipratropium for exacerbations, and that can work real well. And they may need it often, up to every 4 hours. Oral steroids, so with a COPD exacerbation, you may need to do a course of oral steroids. Prednisone or equivalent 40 milligrams per day for 5 days as a burst is typically the recommendation. There's seems like less and less evidence about using tapers. I still do in some cases. There's patients who have been on steroids before. Sometimes they just know that a taper works best to kind of help lower that dose down. But as far as the evidence base goes, doing a burst with 40 or more milligram equivalents of prednisone for 5 days should be just as effective. And then antibiotics. So antibiotics are a little bit controversial. But in patients who have moderate to severe COPD, it's reasonable to add an antibiotic for an exacerbation, especially if they're having sputum production, even if they don't have fever or other signs of pneumonia. And there's it'll come up here, an algorithm that's a little bit hard to read, but again, I could send it out and I can kind of blow it up a little bit here. But basically, if you've got an exacerbation, so you're looking at symptoms, shortness of breath, higher sputum production, you're trying to decide whether to use an antibiotic or not. If the patient's high risk or they've got sputum production, certainly if they've got fever, then you can select an antibiotic. On the right side, it says the most common antibiotics they're used are azithromycin or doxycycline, typically used as you can use Bactrim. I think there's good reason to use azithromycin and doxycycline because both of those antibiotics have anti-inflammatory properties too. And so they can help along with that, even if there's doesn't end up to be a bacterial component, the addition of those medications can help with symptoms. On the left side, if they've got complicated COPD or if you're worried about aspiration or if they've had recent hospitalization, you may need to use Augmentin or a fluoroquinolone. All right, let's check on Javier here. We'll kind of go through this. Part of what our support is with these patients, and we're talking about managing these patients, we need to help them know what to expect. And we've kind of talked about that as far as decline indicators, helping families prepare for exacerbations and know what to look for, when to call us, look for declining function, helping predict their prognosis so we can communicate with them on those things. Discussing prognosis. So if you have trouble with those conversations, there's tools that can be used and just practice on discussing prognosis with patients. I know it's easier with some patients than others. Some patients don't handle that very well. And then it's certainly important to have advanced care planning conversations and use some of those decline indicators that you're seeing to talk about condition and talk about what's ahead so that patients can determine what goals are important to them to see what they would want to do if things get worse, whether they're to that point where they don't want to go to the emergency room or go to the hospital anymore and would not want a ventilator. So it's really important to revisit those advanced care planning discussions. We talked about exacerbations. Patients with worse COPD have more exacerbations. And so the more we can do for them at home, the better. Try to keep them out of the ER and try to catch those exacerbations early. Sometimes we will do an action plan, kind of like asthma for those patients where they have the medications on hand and they know which symptoms correlate with what they should be taking and when to call. So relief of suffering for patients and caregivers. We've talked a little bit about this advanced care planning. They help you understand the patient's goals. Assessing the caregiver helps to assess how everything's doing. That's where we get to use our social workers, our chaplains, and really come together as a team. And then managing symptoms helps relieve suffering and slow progression. Which of these are common sources of suffering? Well, all of them. And so that's why it's important not just to focus on shortness of breath when we're talking about patients with COPD, because they have all these associated symptoms, and we should be asking about these things constantly and evaluating for these things, even if patients don't tell us about them, because we should be care planning for these things. Skip that. Patients, the way they might explain shortness of breath, we've probably heard that because it's not always accurate just to ask how their breathing's doing, because I've seen some patients who can't even speak a full sentence and they say their breathing's fine, and others who look like they're breathing fine, but they're feeling dyspneic. So they might use some other descriptors that chest feels tight, breathing short, it requires effort, they can't get enough air. So it's good to ask a lot of questions to get them to describe that as far as activity level and other associated symptoms. And so one thing I want to make sure is that we talk about specifically management of dyspnea. So this is good for not just the providers, nurses, nurse practitioners, and physicians, but all team members. And so first thing, and this part is geared more towards the nurses and NPs as we're doing clinical assessments. So if you get sent out and you're seeing a patient who has dyspnea, especially if there's a change in dyspnea, don't just automatically jump to the morphine. Really dig in and figure out what's causing dyspnea. Just like anything, any other symptom, you want to look and figure out what's causing it to know what the best treatment is. So we listen to those lung exam findings. So use those. Do they have wheezing, meaning they're in bronchospasm? Do they have some fluid in there and you hear crackles or diminished lung sounds? Are they anxious? Is their lung exam pretty normal, but they're still having shortness of breath and it's really anxiety? Are they hypoxic and it's really just lack of oxygen? Are they having secretions? So, you know, if you have a patient who's complaining of dyspnea, morphine will help to make them feel less dyspneic, but it may not treat the underlying cause. And so it's important to be in tune to those exam findings so that you can help work to figure out what the cause is. I know a lot of the hospice nurses don't carry a pulse ox. And I know we're taught just to treat symptoms, but I think that nurses should carry a pulse ox because I think it's important to know if a patient's dyspneic, if they're actually hypoxic or not. Now, it doesn't mean you're going to necessarily treat the number and obsess over the number, but it is important in that evaluation. So if you don't have a pulse ox, it may be worthwhile to do that because I think those help. Non-pharmacological management. So this would be something that anybody could do. Any team member could advise a patient on. If you're at a visit and the patient's short of breath, you can help them just to relax, try to release some of the anxiety. Fans help, or just something to increase the airflow in the room. So whether they have a little portable fan, if you can open a window if there's airflow and the weather's nice, even just a manual fan, just get a piece of cardboard and get air flowing, that can help relieve some of the sensation of dyspnea. Help them to conserve energy. So if they're anxious, if they're fidgety, if they're doing a lot, try to get them to slow down a little bit because the less energy that you're using, the less oxygen that you'll need. Breath counting. So actually helping a patient to breathe a little bit deeper and slower can help relieve dyspnea. One simple trick is just to have them breathe in for a count of 4, hold their breath if they can to a count of 4, and then breathe out to a count of 6. And that alone, doing that even just once, twice, 3 times can help slow their breathing down and make them feel better. Positioning, if they're not sitting up, or some patients are more comfortable leaning forward a little bit, just make sure they're positioned right. And then if they have oxygen, put it on or turn it up. So these are things that any team member can help with. If you're seeing a patient, if you're a home health aide and you're seeing a patient's dyspneic and you're calling the nurse to come and do an evaluation, but these are some simple things you can help the patients do in the meantime. And then we get to the drugs. So I want to just spend just the last couple minutes on drugs for dyspnea. Certainly know that opioids help dyspnea. Liquid is better, but start low. And this is one thing I want to point out because I know we get used to our Roxanol, our 20 milligrams per milliliter, just because that's in the comfort kits and we give that to patients. But if patients haven't been on an opioid before, or if they're not on something currently and it's been a while, start low. If you're just treating dyspnea, a lot of patients can get good relief just with a simple 1 or 2 milligram dose. And so you could get a 10 milligram per 5 milliliter prescription, or a 20 milligram per 5 milliliter prescription, and use a really small dose, because we know that the tablets don't come in those types of doses. So I just had a patient not long ago who was in the hospital and having terrible dyspnea, and started with a 1 milligram of morphine, and it made a world of difference. He felt like he could go run a marathon. So start low, because if you do go too high too quickly, then you can certainly decrease respirations, and a lot of times that low dose does the trick without the side effects. If patients have anxiety, then a benzodiazepine can be okay to add, but just be careful. Obviously, combining opioids and benzodiazepines, you have higher sedation and can have respiratory effects with that. So certainly appropriate if you think anxiety is a component, but just go slow with those. And then when we talk about end-of-life care, so patients who are actively dying, the treatment is similar to other conditions where patients are actively dying. They have dyspnea. They might require opioids at higher doses, sometimes 10 milligrams, 20 milligrams, 40 milligrams per dose, and you just use what it takes to get them comfortable. Agitation can be common just because shortness of breath can lead to so much anxiety and agitation. Might need a benzodiazepine or Haldol. And then secretions. So just like other patients who are at end of life, actively dying, they tend to have more secretions, and COPD patients might have more than usual just because of the disease process. But the same tools still work for those patients as well. So wrapping up here, yes, Javier should be considered for opioid therapy. Start low. Some of this is duplicate, so we'll kind of speed through this here because we're about out of time. But in this case, so Javier needs an opioid. What's good? As we just talked about, let's use a liquid, really low dose. Start with 1 milligram every couple hours, and he's probably going to get some relief with that. Fly through this to wrap it up. It just shows it's good to make sure if you're using a liquid, make sure you show the patients where to measure it at, because you can always add more medication, but if they take a big dose, it's hard to take it away. And of course, if you've got patients who are on opioids, make sure they've got a bowel regimen. That's really important too. So Javier, we started him on a little bit of morphine, and now he's feeling better. He's in a better mood. He gets to play with his grandkids. He can dress on his own. He hasn't been back to the emergency department. He's doing pretty good. What else can we use for dyspnea management? We didn't talk about these. We did a little bit on the benzos and bronchodilators. What about nebulized opioids? These I've seen used, and really the latest evidence shows that those really aren't as effective. As still, again, I'll see them used some, and there's nothing wrong with it. It's just probably not as effective as just using bronchodilators and oral steroids. Some of these other symptoms we'll kind of skip past. So putting it all together, we've talked about a lot. 911 is not a plan. So we've talked about usual care, patients who are on some of the newer medications, the inhalers, exacerbation treatments and things like that. And then our palliative care treatment. So with Javier, certainly that's appropriate to start having those discussions to describe what to expect, talk about his disease trajectory, and talk about plan at home on what to have and what to do if he's short of breath, and what his wife can help do. And in this case, then Javier, he dies peacefully at home with hospice family at his side. And they've all done better because we've done a good job there. So with that, we'll wrap it up. Just went a few minutes over. Are there questions or comments or concerns? Feel free if anybody wants to unmute and ask a question or has a comment.
I have a quick question.
Sure.
At the risk of sounding a little goofy, with COPD, we have an issue with getting, we're holding on to CO2. So why do you see these patients on CPAP? Can you explain? Because I feel like that doesn't necessarily help with oxygenation.
CPAP would a little bit. I mean, because you're right. Yeah, you've got CO2 accumulation, and it's hard for them to breathe that out completely or get rid of it. But with CPAP or BiPAP, really what you're doing is you're putting that in pressure. That's the biggest part that helps, is you've got pressure that's it's pushing air back into the lungs to help open up the alveoli and those smaller airways a little better. So it's almost, it releases a little bit of the CO2 just by kind of popping open those airways a little bit more. It's kind of a simple way to look at it. And in that way, it would improve oxygenation a little bit by kind of, it makes a little bit more of the lung tissue available to use and carry oxygen. But yeah, and somebody who's really hypercapnic, if they've got really high CO2, or they're really got severe disease. A lot of times CPAP isn't enough, and then they're still going to retain CO2, and just they're still not able to utilize that oxygen, even if you're running oxygen with the CPAP. So.
Okay, thank you.
Sure. Anybody else have a question, comment?
How can we get a copy of the slides?
Since I know Maite sent some invites out, and I don't know who all was on there. So if you want those, just email me. I think my name's on the screen. There's just brian.hughes@crossroadshospice.com. So
Thank you.
Sure, no problem. Yeah, anybody who wants those, just send me an email, and I'll send you the slide set. All right. Well, if nobody else has anything, I really appreciate everybody coming on. It's good to see faces from across the country, Crossroads sites, and hopefully we'll get to do this again if it was helpful. So everybody take care. Have a great evening.
Thank you.
Thank you.
You're welcome.
Thank you.
Thank you.
Thanks, Dr. Hughes.
You're
Thanks
welcome.
a lot. Thank you, Dr. Hughes.
All right. Bye-bye.